Thank you, Paul. It's a great pleasure to be here. And Paul has been a great mentor of mine from the very beginning, and he continues to be a champion for me today. And it's great for me because someone like him, he tells me, as a young person, these ideas are crazy, you shouldn't do this, and you should go this way instead. So in many ways, I've kind of downloaded his knowledge and merged into one person with Paul behind me. So I think I stand here at a very interesting intersection in time, because for a long time, we as transplant physicians, we see patients that have to go back on dialysis, their transplants fail. I can assure you, I don't look sad in front of patients, but it pains me every time. Doesn't matter how long the transplants function, 5 years, 20 years, every time we have to put someone back on dialysis, I think we feel bad about doing that. For a long time, we didn't know why that was the case. And many of our forefathers, they have done a lot of work, and for the first time in the past 5 years, we know why kidneys fail with certainty. Not only that, we have the new tools now. And like many trials in nephrology, many of these medication therapeutics, they have not panned out. And we didn't understand that. But now we have some answers. And importantly, we're at a point in time where we have the solutions that we can move forward. And I think it's a very exciting time to be in transplantation. So I think I'm going to begin by going back to the very first transplant in 1954. And what this diagram is supposed to show here is that over time, you can see that we have a number of immunosuppression medications that have come on. But in addition to that, we also have better characterization through histology, immunology about transplant rejection. What I want to show also in this diagram is that the rejection that was seen in 1954 is very different from what we see today. That's partially why the reason we haven't moved forward in terms of transplant outcomes. And this diagram here kind of shows that nicely. You can see from the era of 1995 to 2000, there has been a marked decrease in the incidence of acute rejection, which translates into better outcome within the first year of after transplant. But what's lagging behind is the long-term outcomes have been stagnant. And that's been a paradox for a long time. Why is it that acute rejection incidence has lowered, but patients are not getting better longevity in terms of their graft function? This important analysis from the University of Alberta basically showed that the dominating problem for long-term allograft loss is really antibody-mediated rejection. And that was elusive for many years. So for the past 5 years, our transplant community has been focused on defining what is the pathophysiology behind antibody-mediated rejection. And on your left, you see that for many reasons, patients after transplant, they start to form these antibodies called donor-specific antibodies, or DSAs. They're targeted against the allograft. For a while, maybe there's no problems that happens to the patient, but over time, many patients, they do develop graft injury that can be acute, indolent, or it just takes a long time to lead to graft dysfunction. This is the phenotype of the rejection that we see today. It doesn't give someone transplant failure right away, but it's very difficult and very resistant to treatment. So knowing this, how do we approach patients today? What are the treatment options that we offer? Well, I would say that if our medications were cheap and they didn't have any toxicities, we'd offer treatments to all patients all the time. But that's not the case. Our medications, as I will show you, are far from perfect. They don't work very well. They have a lot of toxicities, and they're quite expensive to give to patients. So as a transplant physician, we look at many characteristics to determine which other patients we want to treat and which other patients, unfortunately, we don't have a solution in today's environment, and what can we do for these patients in the future. These are the things I look at: the antibody characteristics, the histology, and the clinical. Just to give you an idea, this is one pivotal study published last year, and it confirms for a long time what we understand about rejection. And that is the following. There are two different types of antibody-mediated rejection that we see. One is predominantly caused by preformed antibodies, and for a long time, we were just transplanting patients left and right, particularly about 10, 20 years ago, without regard for whether antibodies were present or not. And these patients would have a very high risk for acute early rejection. But what's interesting is that when you talk to someone like Paul, who has lots of experience in treating these patients, is that they tended to respond well to immunosuppression, as you see on the right, is that their outcome is not severe. Once that they get over the acute rejection with treatment, that their outcomes tend to be okay. What you see the curve on the right, the de novo antibody, these are antibodies not present at the time of transplant, but they will form after transplantation. And they don't cause graft rejection right away, but when they do, they don't go away, they persist. And that is why when you look at graft survival on the right, they tend to do much worse compared to the early rejectors that we see. The antibodies have come a long way as well too. Now we're able to identify what class of antibodies they come from. Is it a class 1, which tend to be more the preformed antibodies, or predominant class 2 are the antibodies that form after transplantation. And I see here, I show here that the DQ-DSA, they are class 2, and they happen across the board, not just in kidney transplantation, but for lung, for heart, for liver, it's the same story, very interesting. And this is an interesting study from last year. What it shows is that, forget about these sophisticated assays, the most important predictor of graft loss is patient non-adherence. So coming back to the theme about integrating holistic care, I had a pharmacology professor many years ago who said, drugs don't work if patients don't take them. And it sounds like duh, but it's very much true. Our medications, they have a lot of toxicities. We don't do a very good job to ask patients, why is it that you don't take these medications? How can we help you take these medications better? Forget about giving patients a lot of immunosuppression at the time of rejection. They're toxic, they don't work well, they're expensive. If they don't take medications going forward, then you're back to where you started. We've done absolutely nothing for these patients, and we've only begun to realize that. So this is kind of where we stand today. As a physician, given the inadequacies of our treatments, we still have to have an approach to treat our patients today. And what I show here is that this is really the inspiration, is that for the past 4 years, we've come to realize the transplanters, even though there's only 6 of us right now, we all have a different threshold to treatment. And as physicians in the room, you may see that, is that one person may be more aggressive in treating one patient, another physician may do completely different. We had a lot of consensus building. We came up with this algorithm, which will apply to all the patients in the province that get referred to us now. And what you see here is that when someone tends to have rejection early young, we are much more aggressive. It's because they tend to have more kidney function to salvage. But towards the end, because we may catch patients in the middle or towards the end of their antibody-mediated rejection trajectory, we're much less enthusiastic, and it's because the data doesn't support that, as I'm gonna show you. How do we treat patients? I'm sure many of the physicians and nurses have seen this protocol before. The standard of care is plasmapheresis and IVIG. There are 2 kinds of IVIG that we give. One is a low dose protocol and one is a high dose protocol. You can see that's the standard of care as defined by the FDA workshop in 2011 and also by KDIGO. But what is the evidence behind this? This is a study just published this year, which is a BAM survey. They sent out a survey to about 100 transplant nephrologists across the world, asking them, how do you treat antibody-mediated rejection? And I don't feel so bad that I don't have all the answers, because if you look at the answers given by all the transplant nephrologists worldwide, everybody treats them differently, which means that we don't have good medications. We don't have a good solutions today. But we still need to have some kind of a protocol so that we can move forward, so we can assess our outcomes and remedy our protocol based on new data that come in. This is a protocol that our transplanters came up with in the province, and we've been applying this protocol for the past year. This is an IVIG plasmapheresis protocol with Rituximab. I get a lot of calls about urgent plasmapheresis for patients with antibody-mediated rejection. Is that warranted? This is a meta-analysis published this year, which shows that the evidence for the standard of care that we have today is pretty modest. You can see the overall compilation of hazard ratio, it's pretty much at the line of unity. What about Rituximab? Many of you know that Rituximab is an interesting molecule, medication which targets B cells at the CD20 receptors. Like many things that we do in nephrology, we kind of add medications based on small case series, and we don't have rigorous evidence to support it. But for the first time, we have a double-blinded, randomized placebo-controlled trial by the Paris group, published just a couple years ago. And they were using this study to determine whether there's any benefit in adding Rituximab to plasmapheresis and IVIG in the management of acute ABMR. And what I found was that there was no difference whatsoever in GFR, in graft loss, and in reducing the titer of antibodies. That was the one-year outcome, and when they extended the study to 5 years, published last year, again, they did not see any benefit of adding Rituximab. Now, Rituximab is a good medication, but how come it doesn't work for our patients? And we've begun to realize, if you look at the physiology of Rituximab, is that as B cells mature, eventually they become plasma cells. And when they do become plasma cells, they shed their CD20 receptors. So if you're giving someone a medication that targets only CD20 receptors, and yet they have plasma cells making antibodies, you're not going to solve the problem. So we've understood now why Rituximab on its own is not going to be the solution for AMR. What about new medications? There is a medication called bortezomib. Many of you will have known this from the treatment of multiple myeloma. It targets the proteasome inside cells, inside the activated B cells, particularly plasma cells. This year, for the first time, there is a randomized placebo-controlled trial on using bortezomib in our patients with late ABMR. And surprise, surprise, what I found was that there was no difference in outcomes at the end. And it sounds discouraging, but I think through these trials, we're starting to find out why is it that these new therapeutics don't work, like many things in nephrology, and that is because the disease is complicated. And to show you why bortezomib on its own is not a solution, it's because on your left-hand side, this is a basic science study, so forgive me, but I think it's a very nice study to tell us about pathophysiology. If you culture the plasma cells that make antibodies, and you give them bortezomib, you can see in the dish there that the plasma cells, they do go away. And in the left bottom diagram, that the antibody secreting cells, they do go away. However, there is a compensatory B cell proliferation in the germinal centers that bounce back after you deplete the plasma cells. And this process kind of forms new B cells, activated B cells. So the process is really not halted. You know, you've taken care of the downstream plasma cells, but new B cells are still being recruited. And that is perhaps why bortezomib on its own will not solve our patients with ABMR. Many of you will have seen this medication called eculizumab, which is being used for the management of atypical HUS. It has been dubbed the world's most expensive medication. And of course, as transplanters, we have to try it out. Partially because antibodies mediate injury through activation of the complement cascade. So what I show you, the diagram on the left-hand side is that you have antibodies binding to the graft endothelium. It activates the complement, and you see the C5 being cleaved and deposited at the end. So eculizumab blocks C5. So naturally, one would think that if I can block the complement cascade, patients must be able to do much better, and that's what we tried on. This is a study from a Mayo Clinic. They give patients eculizumab up to a whole year. And what I found was that when they follow patients long-term, these patients had a lower risk of antibody-mediated rejection, but their graft outcomes were similar in the long term. Why might that be the case? If you look a step further, if you block C5, there's a lot of pro-inflammatory cytokines being generated before that, such as C3, that also cause injury. So now there's another new medication called the C1 inhibitor, which is blocking more proximal in a complement cascade, and we don't have good data to show the outcome so far. This is another interesting molecule, medication, that's come into our toolbox as of last year. So this is a IgG degrading enzyme. Someone has this excellent idea, I think, that if you can take this enzyme, which is cultured from Strep pyrogenes, which is a bacterium that causes infection, what it does is that it cleaves the antibody at a hinge portion, and you effectively render that antibody useless. In the panel on the right, you will see that, yes, this medication is highly effective. If you give it to patients with very high concentration of antibodies, within a few hours, their antibodies completely go away. But what you see is that these antibodies, they come back on the right. So what happens when they try this medication in the number of transplant patients? And you can see that in the left-hand side and then right-hand side, two different cohorts, one from Sweden, one from the US. These antibodies completely went away at the time the medication was given within a few hours. But virtually by week 1 to week 2, these antibodies returned and they caused rejection right away. But for the first time, we actually have a medication that can actually remove all antibodies, and that's very useful. So if I can summarize the medications that we have today and the upcoming medications, why they don't work. In Rituximab, it doesn't target plasma cells. In Bortezomib, you target the plasma cells, but there's a rebound generation of activated B cells in the germinal center. With complement inhibitors, there are non-complement mediated pathways that also cause rejection. And in the new medication, IDAS, there's a rebound antibody production. And it seems like we should just give up now because it's not a lack of therapeutics, it's that this disease, like many in kidney care, there are duplicated pathways. And when you take care of one, the other pathways, they can still cause a problem. But I would say that for the first time, we have so many medications, we can learn to use them in combination by blocking different pathways. And so far, there's preliminary studies showing that that has been proven to be very effective. And I think that's where we're gonna go in the future, is by using medications in a way that's rational, that fits the pathophysiology and at a per patient level. But what do we do for patients in the meantime? We cannot rely just on medications. And I think the theme that you see here is that once the immune system is activated, when the B cells are activated, it's very difficult to shut down the process. And that is because humans were not designed for transplantation. Our immune system was designed to fight infection, that it has to combat all kinds of pathogens we see in the world. And that's why it's so difficult to suppress it in the nature that is unnatural. So the best way that we have going forward is really to have prevention. And I would talk to you now about 3 ways I believe would be the best strategy going forward to to eradicate ABMR. The first one is to systematically target non-adherence. Second one is to optimize immunosuppression. And the third way is I think transplantation has come full circle. We're gonna talk about matching again. What is the burden of non-adherence in ABMR? If you look at this pie chart again, there are about 50% of patients with graft loss due to AMR, but half of them are non-adherent. So without any new fancy medications, if you can address non-adherent patients, you've taken away half of those patients who would otherwise get antibody-mediated rejection. And I have to say, we haven't done a very good job in doing that so far. We haven't tracked what is the prevalence and incidence of non-adherence in our transplant clinic. And we haven't really teased out why is it that patients don't take medications. Some patients may simply forget. Some may not want to take them because of toxicities, and others may have other reasons as well. So this is a very exciting pilot study. It's been led by Cindy Luo, who is our transplant pharmacist at VGH. We have a small grant to study, in the current environment, can we use updated tools to understand adherence? We've partnered with a company which has an app that everybody can download on their iPhone. And basically what it does is that every time there's a medication to be given, it reminds them. And if you don't take it, you have to list out the reason why. That allows us to track these patients. What is the frequency that they actually miss medications? And what are the reasons behind that? So hopefully in the future, everybody can have this on their app. And we can, for the first time, address the reasons individually why certain medications are being forgotten and what we can, as physicians, do. The second thing is about optimizing immunosuppression. We talk about this all the time, but how can we actually do that? As many of you know, we check therapeutic TAC levels for patients, but many of these levels were defined at a time when transplant rejection was entirely different from what we see today. Going back to my very first slide in the presentation, back then they were just worried about overcoming acute rejection in the first 6 months post-transplant. That's how these levels were defined. But today, we're worrying about antibody formation. So there's a lot of studies now working on finding the exact targets and at the individual level that for this particular person, perhaps the standard of care target may not work for them for many reasons. I've been interested in mycophenolate, And that is because, anecdotally, I know that many patients, they cannot take the mycophenolate dose that we give them. This is a study that was presented just 2 weeks ago at CST. We're getting ready to publish this. So what it shows you here is that we give all patients in the transplant clinic, they start at the same dose, 2,000 milligrams per day. But how many patients can actually take that? And you can see that by the end of the first year, 64% of patients, this is BC data, they've had a dose reduction. They're no longer taking the recommended dose of mycophenolate anymore. And to me, that's huge, because these are patients for whom physicians have told them to reduce immunosuppression because of one toxicity reason or the other. We also don't know what's the impact of that on long-term outcomes, and that was the focus of the study here. And what we show here is that, perhaps not surprisingly, in those patients with a severe mycophenolate dose reduction, that had the worst long-term outcomes in the future. What we'll see is that many patients, they have dose reduction, but their outcomes are still okay. And this is where we get into personalized medicine, is that for which patients can we safely reduce immunosuppression, and for which ones they really have to stick to the target 2,000 milligrams per day. And I think we're in the infancy of finding that out. This is a multivariable model, and basically what it shows, again, is that in patients with the most severe amount of immunosuppression reduction with mycophenolate, it didn't matter which variables we adjusted for, they had a hazard ratio of 3 to 4-fold of graft loss in the long term. So how can we address all these problems? And I think we've come full circle in transplantation, in that we remember the first kidney transplant was performed between identical twins when there was no immunosuppression, and they did not see rejection. Why don't we do this anymore? When we talk about matching between donor and recipient, we talk about matching between HLA molecules. On the left-hand side, you will see that the data from 1985 to 1994, people were looking at this problem. And that is because back then, they did not have good immunosuppression, so they had to rely on better matching between patients. You can definitely see that those patients with 0 mismatch, they had the best outcomes over time compared to 6 out of 6 mismatches. With better immunosuppression in the current era between 1995 and to the present day, you can see that the difference in graft outcomes is much muted. And then we kind of said, well, that's because we have better medications. We don't have to worry about matching anymore, and that's true. We don't really care about matching. We don't really pay regard for that when we allocate kidneys. But this is the problem that we see today, and many of you who practice in the transplant clinic know this, is that in our standard of care medications, about 60% of patients, they will do just fine. We see them, takes 5 minutes, they're in and out, they don't get toxicities, they don't get rejection, and they're easy patients. However, for about 20% of patients, they're constantly getting infections, they're getting cancers being formed, they're getting other toxicities like diarrhea, leukopenia, and so on. And there's the other 20% of patients, our immunosuppression standard of care doesn't do the job to prevent rejection. And they're coming back to us with rejection. We have to give them even more immunosuppression. And what you end up with is a constant back and forth between over-immunosuppression and under-immunosuppression. And that is why our outcomes haven't changed in the past 15 years. So how can we target this problem and go forward? So if we remember the first kidney transplant between identical twins, if we have a way to match patients and their donors better, perhaps we don't need to give so much immunosuppression anymore because their risk of rejection is lower, and therefore they won't get the same amount of toxicities. And how are we going to do that? A buzzword that you may see in the publications today is Epitope. And I think that's a very exciting concept. This concept is not necessarily new, but we just never had the tools to actually implement it. When antibodies are formed, they don't recognize the entire HLA molecule. They kind of recognize discrete patches of amino acids on the surface of the HLA molecule that cause rejection. So I'm going to give you an example here to tell you what we do today and what we can do differently tomorrow. If you have a patient, and I give you a recipient with HLA-B7, and there are 3 different donors being allocated today, each one of the donor has 1 antigen mismatch with the patient by our conventional criteria. But if you look at the amino acid structure, and you see there, what you see in the yellow is that these are the differences between the donor and recipient. And basically, you will see that for donor number 1, it's a 1 antigen mismatch, but if you look at the amino acid level, they're actually not all that different. In comparison to donor 3, they're also viewed as a 1 antigen mismatch, but there are many amino acid differences between the donor and recipient. So right away, I think you can see that our current classification is not really granular enough to tell us about the close immunogenicity differences between donor and recipients. To further drive the point home, I perform alignment of the amino acid levels between the recipient and the 3 donors on the right. And I think what you can see, again, is that for donor number 1, there's only 1 amino acid difference between the donor and recipient. Donor 2 has 2, and donor 3 has many. Under the current scheme, all of them are perceived as the same degree of mismatch, when that's actually not true. So this group in Manitoba, they have done the work to kind of say, okay, is this just theoretical, or does it translate into outcomes? They took their patients, and what you see here is that in the 0 mismatch patients, nobody had antibody formations. But in the 1 mismatch and 2 mismatch, they had antibody formation about the same degree. But if you apply the new strategy that we talk about using the epitope matching way to look at amino acid differences between donor and recipient, you can see that actually many of them, between 1 and 2 mismatches, they would have done fine under this new way to classify patients. How are we going to do this? And Paul and I talk about this on a daily basis, is that it's a complicated process, but when you break it down into the workflow, it's actually not that difficult. What you do is that you need a DNA between the donor and recipient. You put it into a sequencer, such as this one, and it spits out a high-resolution typing. We put that typing into a software, which basically takes the sequence of the genetic sequence between donor and recipient. It takes that and folds it into a protein structure, and using that to compare the amino acid differences I just alluded to. The sequencer that we have today is kind of bulky. It takes about a week to sequence patients, and that's not a practical solution for deceased donor transplants where you need a turnaround time of only a few hours. And there are many exciting technologies we're looking at in the lab to say, how can we do this in a faster turnaround time? One of the things that's very exciting is the Nano4 Oxford technology here. The shape is like a USB, and you can literally plug into a computer. You can pipette your serum, the DNA, and right away you can get turnaround time within a few hours to get the sequence information. And I think that's where we're going in the future. We're using this in the lab for HOA, but broadly, I think for personalized medicine in the future, that's the path. Once you get the sequences out and you get the high resolution typing, you literally put it into a computer system like this. You put a patient type in, donor type in, and there you go. You got a number of mismatches. And that is information we can now put into our reports to inform physicians how closely matched your donor recipients are. So if you need to reduce immunosuppression, you know whether you can do that with certainty or you're going to get into risk with rejection. So as Dr. Dalton said, I think under the leadership of Dr. Paul Keyoung, who is the primary investigator for a large-scale genome grant that was awarded this year, there are many things we want to talk about, what we want to do in this grant. And the overall arching goal of this grant is to advance precision medicine in transplantation to overcome ABMR. And this is a very nice diagram where what we hope to do in the next 5 years is to get to a state where we can risk stratify patients from the very beginning of transplant and say, okay, based on this donor that you get, you can be classified into a high immune risk patient, medium, or low immune risk patient. We're going to integrate their pharmacokinetics, pharmacodynamics, and genomic information to determine how these patients metabolize their therapeutics. We know that if I give 2 different patients the same dose of medications, not all of them will metabolize it in the same way. Some people will need less of it, some people will need more of it. And for the first time, we're going to integrate that information into our risk prediction. And what that allows us is to really understand which patients can we start to minimize immunosuppression because they were low risk to begin with, and which are the patients that you need to pay attention to that they need more immunosuppression. We're also going to factor in adherence as well. So for the first time, we'll have a holistic approach to patients to understand, these are the patients will do just fine. You don't need to spend a whole lot of money to monitor these patients, and which are the bad actors that we need to focus our attention on. So I think I'll end there and take questions.